Good afternoon, everyone, and thank you for joining us. My name is Michelle Knighton, and I'm the Health IT Test Lab Manager at ICSA Labs. I know I've worked with many of you in the past, both during my time here at ICSA Labs as well as my tenure at CCHIT. I'm going to be hosting the first portion of our webinar today, and then I'll turn it over to my colleague, Kevin Brown, who is our Certification Body Manager, and he'll complete the last half of the webinar with you. We are pleased to present our ongoing 2015 edition webinar series over the testing requirements, and today we're going to be focusing on the public health and automated measures criteria, the direct criteria, as well as the CCDA creation performance criterion. And those map the criteria F1 through 7, G1 through 2, G6, and H1 through 2. We do have some additional webinars scheduled over the coming weeks, and we hope you'll be able to join us for those as well. And we'll be talking about those a little bit later today. Next, a few housekeeping items. Please go ahead and mute yourself. We are recording this session, and we're going to post it online by next week along with the slide deck. We'll send out an email notification to all of the registrants to advise when these are available. If you do have questions during today's session, please make sure you submit those using the chat feature of WebEx. So what we'd like to go over today, we're going to provide a brief overview of ICSA Labs for those on the call who may be unfamiliar with us. Next, I'll provide an overview of the items relevant to the criteria we're discussing today, followed by a review of the testing requirements for those public health criteria, as well as the delay in being able to certify criterion F5. After that, we're going to talk about 3 of the design and performance criteria. So mainly those would be the automated measure criteria, G1 and G2, as well as G6, the CCDA performance criterion. After that, Kevin is going to walk you through the test requirements for H1 and 2, which are the 2 direct criteria. And then we're just going to wrap up the day with some next steps, including the anticipated program launch and our upcoming webinars. So first, a little bit about us. We have been around for over 25 years. We provide organizations with expert third-party evaluations of both deployed and proposed technologies. And we were actually the first commercial lab to receive ISO 17025 accreditation for information security testing. As you know, we have significant involvement in the health IT space. We conduct testing and certification for the ONC's Health IT Certification Program, Concert by HIMSS, the IET International Conformity Assessment Program, and as we just discussed last week at HIMSS, we made an announcement that we are in partnership with HIMSS and CNI Advantage to perform testing of the new CDC immunization program. Just a little bit about the different accreditations that we hold. We have ISO 9001 accreditation for our quality management systems. We're also accredited by ANSI as a certification body for the ISO 17065 standards, and we're ISO 17025 accredited by NASLab, and that's for our test lab. And of course, we also have ONC-Authorization as a certification body and test lab. Okay, those of you who have seen the slides before, have attended some of these webinars, the next few slides are going to be very familiar to you. Essentially, these are the core categories of different certification criteria. There are 60 criteria total. The ones in blue on this slide are the ones we're going to be talking about today. However, we're only going to be talking about 3 of the design and performance criteria, not all 9 of them. We'll be talking about some of those others on the 24th of this month. So hopefully you'll be able to join us for that webinar. Just a quick overview of the criteria type definitions. Unchanged criteria are gap eligible. Revised criteria means that something has changed, they added some capabilities, or was a new capability that wasn't previously part of the criterion, and then brand new criteria, so it's never been tested before in this program. So in the unchanged category for the set of criteria we're looking at today, we just have 1 criterion that's gap eligible, and that's the reportable labs criterion. We have 7 that have been revised. So immunization, syndromic surveillance, cancer registries have all been revised in the public health space. For automated measures, both G1 and G2 have been revised. And then H1 and H2, which we saw as a result of the 2014 edition release 2 criteria, those have been revised as well. We have 4 new criteria. So 3 of them in public health. So we have electronic case reporting, antimicrobial use, healthcare surveys, and then in the design and performance category, we have the CCDA creation performance. First, I'm going to go over the public health criteria and what those test requirements look like for the 2015 program. First, we have criterion F1. This is our immunization registries criterion. So in the 2014 program, you'll remember we had 2 separate criteria, F1 and F2. One was for immunization information, and the other one was for transmission of the data, even though a transport protocol wasn't actually specified. So here in the 2015 program, we have an addendum that was issued in July of last year. There are no substantive changes to the HL7 2.5.1 requirement. However, what it does is it consolidates information that clarifies those requirements for conformance testing. Now, you also know we have CVX and NDC codes here. So what the ONC has said is that for the purpose of administered vaccines, so when the immunization is reported at the time it's administered and the actual product is known, that's when you're going to send the NDC code. When you're sending historical vaccines and the actual NDC code is not available, that's when you're going to send the CVX code. You're also going to need to access patient information, forecast, and history from registries. So the ONC does understand that sometimes your system may have a version of the immunization history that differs from the information history that you're receiving from the immunization registry. And likewise, your system might then forecast differently, right, than what, the immunization registry is indicating the forecast should be. They understand those discrepancies and that will happen. Regardless, though, they want your system to still be able to receive the history and forecast from the registry. So based on compliance with the Release 1.5 of the implementation guide, it states that a user would be able to see and compare the history and forecast from the system with the history and forecast from the immunization registry. However, how you display that information to allow for that comparison or reconciliation is up to you. The ONC hasn't specified any particular workflow or reconciliation requirements. Also, transport is, again, not required in the 2015 edition program. However, you will notice if you look at the test tool that SOAP in a very specific implementation has been added. You certainly can use that for certification testing, and if you do, it will probably make that test go a little faster, but it is not required that you use it. Also submitting batch files, that's just a clarification that they made. So if your system doesn't create individual files at a single point, instead it creates batch files, that's perfectly acceptable as well. Okay, turning our attention to syndromic surveillance, and before I get into that, I just want to remind you, you'll see these icons in the top right corner of each slide, and that just tells you some of the dependencies. So, for example, most of the criteria in the public health domain require you to also test to D1 through 3, D7, and G4 to 5. So that's just a quick reference for you. Okay, so back to the differences. In the 2014 program, we saw that for the inpatient domain, the SIN messaging guide was required. It was optional for ambulatory. Instead, ambulatory systems could simply create an HL7 message and not have to comply with those SIN messaging requirements. We also had 3 different scenarios, so urgent care, ED, and mortality, which in the test tool was sweetly named patient dies. And so those things have changed in the 2015 program. So you will now see that all of the care settings have to use SIN. So that means if you're an ambulatory system, there is no certification requirement per se for the ambulatory care setting. Typically, what we would anticipate is those ambulatory systems that once certified to this criterion would likely do so using the urgent care setting. As far as the standards go, Release 2.0 of the SIN messaging guide has been released, and we have an erratum that was released back in August for the inpatient care setting, and it clarifies some of those conformance requirements of the IG. You will also see that we have 4 scenarios instead of just 3 scenarios. So they're now urgent care, ED visit, patient dies, ED visit with an inpatient admission, and then an inpatient visit scenario. So 4 different scenarios now. And again, just like with immunizations, there's no transport required. Okay, F3, reportable labs. This is a GAP criterion, so GAP eligible. In the 2014 edition program, you will note that this was an inpatient-only criterion. And again, they have said that they have intended for this criterion to be limited to inpatient ED care settings. You might have sort of a hybrid ambulatory system, and so maybe you would be able to do this as well, but it's really intended for inpatient ED. There has been a clarification document released. So in the implementation guide, RE, which stands for required but may be empty, it's not optional in the IG. So required but empty means it is a required segment. It has to be implemented in your system, but operationally we understand that in some cases the data may or may not be present. Also in the implementation guide, alternate and non-alternate data elements have been specified, and they've done that to ensure your system can support both types of data elements. And when they say support, the examples they've given are being able to receive, process, store, and send that data. Also, any text for patients and providers are also labeled RE, so therefore those segments are not optional. Also, repeatable fields. So, for example, this patient ID field, you can have unlimited repeatable instances. So your system has to be able to support that. The test tool is testing a minimum of 2 instances of it, but just know when your system is implemented, the requirement is that it can support unlimited repeatable instances of those specific fields, and this is just an example of one. That means that if your system is deployed and it's been certified and your users say that it's not supporting those unlimited repeatable instances, that does give them recourse to go back to the certification body. So just make sure that you're fully implementing the requirements, that you're not just building your system for testing. Again, just like for the previous 2 criteria, there's no transport required. Now for these last 2 bullets, when you get the slide deck, and you should have it by next week, I put hyperlinks here so that you can access this information. But just quickly, the CDC has published what's called the Reportable Condition Mapping Table, so RCMT, and that's providing a subset of ONC and SNOMED codes that are associated with reportable conditions. And you can obtain that from the CDC vocab server, and that's where that link will take you. The last bullet, the ONC SDO has created a tool known as RELMA, and that helps to map the local lab tests to standard ONC lab tests, and so we've also provided the hyperlink there for you. Okay, S4, transmission to cancer registries. Just like immunizations, we had 2 criteria in the 2014 program, and we only have 1 now in the 2015 program. We also have some updated implementation guides. You'll note that they did not include mapping to the North American Association of Central Cancer Registries, which is a bit of a mouthful, and they did not include those mapping rules because they're very complex and they can change over time. You'll see that we have both ONC and SNOMED updated vocabs there. Again, this criterion is intended for the ambulatory care setting, just like in the last criterion, it was intended for inpatient. Now, the last 2 bullets on this slide specifically talk about testing, so we just want you to know what looks different from when you may have tested this in the 2014 program. So, test case 1 in the tool, you have 2 options, test case 1A or 1B. And so you will choose one of those options depending on whether or not your system collects radiation treatment data. So that's the deviation there. You can pick either one. It's up to you. And then the new testing is that we're testing updates to information. So, for example, test case 4 is an update to test case 3. So just be aware of that. Okay. Electronic case reporting, this is a brand new criterion. So the next 3 criteria I'm going to talk about are brand new. So as far as testing goes, your system has to be able to consume and maintain a table of trigger codes, and this will help your system determine which encounters should initiate an initial case report being sent to the public health agency. Your system has to be able to match a patient and encounter to the trigger code using the code table, and when that trigger is matched, your system has to electronically create that initial case report with very specific data elements. And so I've listed those here for you. So the entire common clinical data set, the encounter diagnosis using ICD-10 or SNOMED, the provider's name, office contact, info, and reason for visit, and then an identifier that represents the row and version of the trigger table that triggered the case report. So those are all the test requirements. As far as clarifications go, there's no content exchange standard that's been specified. And sometime in the future, the ONC has said that an optional tool might be available for use. So you can use the tool to meet the requirements of this criterion, but it wouldn't be required. And then I just put up here some sample standards that they've indicated the tool might support. This is also a criterion that we should be cognizant of the fact that when the program launches, which we anticipate will be at the end of this month, that the test tool and the test procedure aren't available. So you won't actually be able to test this. We are anticipating it will happen sometime this summer, but we don't have a firm date on that. Okay, antimicrobial use and resistance reporting. So as far as testing goes, excuse me, of this new criterion, it does require 3 sections of the HL7 implementation guide, and those sections are the healthcare-associated infection, antimicrobial use and resistance, antimicrobial resistance option report, which is the numerator, the antimicrobial resistance option summary report, which is denominator information, and then the antimicrobial use summary report, which includes both numerator and denominator information. For each of those reports, the system has to be able to create a CDA doc. As far as clarifications go, the ONC has just reminded us that the information is going to be collected by the CDC only, so it's not going to be at the jurisdictional level. They've also provided us with an email address if you need support for testing the criterion or support for the test tool, and so we've provided that here on the slide for you. Last in the public health domain is healthcare surveys, so this is also a new criterion. The first thing I want you to pay attention to is the first 2 bullets on each of these sections. So under the 2015 edition testing and 2015 edition clarifications portion, you'll notice that on the left-hand side, the test procedure says that you only have to test what's applicable, meaning you only have to test the healthcare survey that maps to the domain that makes sense for your system, which is outpatient, ED, or inpatient. However, the final rule is very adamant, as is the companion guide. It uses things like underlining the word must and it talks about that testing covers the entire implementation guide, seeming to imply that if you want certified to this criterion, you have to be able to support all 3 healthcare surveys. We don't think that's what they mean by that, but we can see how it will be interpreted as such. So just know that we have submitted clarification to the ONC on that, and we just did that this week. And so once we get some information back, we'll be providing some additional guidance around that. Back to the testing, so you're going to have to be able to create healthcare survey data for electronic submission, and you're going to do that using CCDA. And then, again, just the notification here that the information that's collected is by the CDC. It's not being collected at the jurisdictional level. So that ends the information I wanted to go over with you. I'm going to go ahead and turn it over to Kevin Brown so he can wrap up the day. Go ahead, Kevin.
Thank you, Michelle. Next slide, please. We're going to talk about the automated measure criteria here, and for those of you who did testing in 2014, I'm sure this is your favorite one to test. If you remember from 2014, for anybody obtaining certification against several of the criteria, at a minimum G1 was required, or you could optionally certify to G2. If you were doing what used to be known as a complete certification, G2 was required. That is no longer the case. G1 and G2 now are both optional, but something that's really important that I want to start off with here, it's actually the third bullet under the 2015 edition changes. You need to certify to either G1 or G2 for products that want to meet the certified EHR technology definition so that eligible providers, eligible hospitals, and eligible critical access hospitals can qualify for incentive reimbursements. Now, the certified EHR technology definition is no longer in the ONC final rule. It is now defined by CMS in the Stage 3 final rule instead. So this program, because it's targeted to more than just the incentive payment program, they've taken that certified EHR technology definition out of it. But if you're selling your product to end users who are going to be using that product to qualify for the incentive payments, then your product will need to be certified to either G1 or G2. If your end users will not be applying for incentive payments, you are not required to certify it to either G1 or G2. That's probably the most important thing I can talk about with these two criteria here today. As far as the testing goes, in the past, there was occasionally be some confusion because ONC used their own names for the measures that were separate and distinct from the CMS names. So, ONC might call it the view, download, transmit measure. CMS called it the patient electronic access measure. Another thing we would see is ONC called them Measure A, Measure B. CMS called them Measure 1, Measure 2. Fortunately, ONC has reconciled those differences, and they are now using the same terminology that CMS uses for the most part. There are fewer measures tested than before. Inpatient products previously would need to demonstrate that they could do a full fiscal year reporting period, as well as during the full fiscal year, the 4 fiscal year quarters. All products, whether inpatient or ambulatory, well, I should clarify, since ambulatory and inpatient are technically no longer designations for certification, it won't matter in that regard anyway, but whether you're intending to get certified for inpatient end users or ambulatory end users, everyone's going to be using calendar year reporting periods now. There's no longer a requirement for fiscal year. Let's see here. So another area that's really important to talk about here with these criteria is, and this is something we only saw a little bit of in 2014, and we're seeing more of it here in 2015, is that some of the measures require functionality that is not required by the corresponding criteria. And there are four that we're aware of at this time: e-prescribing, transitions of care, view, download, transmit, and secure messaging. The details are very nuanced, so in the guidance materials that we're producing, we go through and we explain what those differences are. I don't have time to go into all of them here today, but just to give you one example, in secure messaging under 2014, certified products were required to demonstrate that they could send and receive messages between a provider and a patient, as well as between a provider and an authorized patient representative. Under 2015, the criteria no longer requires sending messages between a provider and an authorized patient representative. However, for the demonstration of G1 and G2, they do state that when sending a message between a provider and the authorized patient representative, that should still count to increment the numerator. So it's just one example of the type of functionality that CMS is expecting you to have to generate the correct measure reports, but ONC does not require that functionality for the associated criteria. So these are some of the things you need to be on the lookout for. So just making sure that you have all that required functionality, even if it's not part of the criteria. The last thing I want to talk about is the section in blue there. Those of you, again, who tested under 2014 probably remember that even after end users were not permitted to attest to Stage 1, to be certified, you still had to demonstrate both Stage 1 and Stage 2 measure reports. Well, in this case, the Stage 3 measures are not going to be applicable until calendar year 2017. However, to be certified, you will still need to demonstrate the Stage 3 reports along with the Stage 2 reports, regardless when you're being certified. All right, next slide, please. So now we're going to talk about the CCDA performance criteria. Next slide. Now, for 2015, this is a new criterion. It is not tested independently. The requirements are incorporated into the other criteria, and you can see a list there, B1, 2, 4, 6, and 9, as well as E1 and G9. The test procedure states that where applicable, you may only need to demonstrate the requirements for G6 once and have it apply across multiple criteria. That could be a bit misleading, though, because some of those criteria require different CCDA document templates. So while that is true that you may only need to demonstrate certain aspects of G6 once for across multiple criteria, that's going to vary between a criteria and some of the individual requirements. If you've been following along on the other slides or the other webinars we've given, you're probably aware by now that for the CCDA, they've updated to release 2.1, and the Common Clinical Data Set now replaces what used to be known as the Common MU Data Set. And so those are both changes that apply to this and pretty much any of the other criteria that deal with the CCDAs. And as I mentioned before, the document level templates, they're specified in the applicable criteria. So G6 isn't going to tell you which document level templates are required by B1. You're going to have to go look at B1 to see which document level templates are required at that criteria. Next slide, please. All right, so now we're going to talk about some of the direct project criteria. Next slide. And this involves H1 and H2. Now, originally in 2014, there were no H1, H2, or H3 specific criteria. However, when they came out with the 2014 release 2, and Michelle touched on this earlier, they came out with H1, H2, and H3. They've now pared that down to just H1 and H2. These criteria are essentially for health information service providers, so what we call HISPs. And some of the changes from 2014 R2 involved, it used to be possible when you were sending direct messages, you could send and receive unwrapped, and if you wanted, you could optionally test wrapped as well. Wrapped only is required, unwrapped is no longer permitted for certification. They've added in a lot of negative testing that didn't previously exist. They've upgraded to version 1.2, the applicability statement for secure health transport. Another big area that they've changed is MDN testing, and they're going with the implementation guide for delivery notification in direct version 1.0. The protocols that you would be demonstrating for H1 would be some combination of XDR, SMTP, IMAP, or POP3. So again, these criteria are for products operating as a HISP. So as part of the demonstration, you're going to need to demonstrate send and receive between the EHR or patient portal via Edge, and then sending and receiving with other HISPs using the direct backbone protocols. So there's a lot of different protocols here that you'll be demonstrating. And one of the let's say last-minute requirements that they've added is this, what they refer to as partner testing. And this is a significant change from a lot of the previous requirements. So in addition to what you need to demonstrate on the day of the test, to be certified to H1, you're going to need to provide evidence of testing with at least 3 different and unrelated partners using Direct 1.2. That's the applicability statement for secure health transport. The partners themselves do not have to be certified, but they have to comply with the criteria requirements all the same. So what this means is for each product wanting to test to H1 or H2, you're going to need to find on your own 3 other partners who are implementing 1.2, the applicability statement, and you're going to need to document, or I should say provide evidence of sending and receiving the messages, including MDNs, and you're going to need to submit that to us prior to the day of your test as evidence that you can successfully work with these other products. Our understanding is this is as a direct result of some of the products that were certified under 2014 when deployed in the real world had problems interoperating with other certified technology. So they want to make sure that you can demonstrate that the product actually is interoperable in the real world, not just in a test environment. We as a test lab are not going to, at this time, be able to facilitate this outside testing. It is something that you'll need to address on your own. If that changes, if there's a way in which maybe we can address that in the future, we will update you as that information becomes available. Next slide, please. So this one, H2, is very similar to H1, but it includes some additional optional protocols. So again, send and receive wrapped only, a lot of the same negative testing. But they've also added in a requirement for the XDR and XDM for direct messaging specification version 1.0. So for the edge protocols, in addition to XDR, SMTP, IMAP, and POP3, they've added XDM. Also, same thing with the partner testing, and same thing with how you're going to demonstrate as a HISP doing edge protocols with an EHR and or patient portal, and the direct backbone with other HISPs. So the differences between these primarily is with the XDM requirements. The reason for the two different criteria is in order to achieve the base EHR definition for certified EHR technology, an EHR will need to be certified to B1, the transitions of care, along with either H1 or H2. Now, from a product standpoint, we anticipate that in many cases, a product that's certified to either H1 or H2 might be wholly separate from products that are certified to B1, but for eligible providers and hospitals who are using these products, they need to make sure that the technology they're using incorporates B1 as well as a product that does either H1 or H2. So as an individual product, you don't necessarily need to do B1 and either H1 or H2, but you'll need to do, if you're a HISP, you'll need to do either H1 or H2 in order for your customers to be able to qualify for those meaningful use payments. Next slide, please. So we're going to talk a little bit about next steps here. Next slide. I know we've told some of you that our prep packet and study guide would be available earlier this month. We wanted to give you a quick update on that. We've gotten a lot of great questions during the previous webinars we've done, as well as finding some of our own discrepancies between the test tools, test procedures, CCGs, and so on. As a result, we've submitted a number of questions to ONC for further interpretation and clarifications. And at this time, we're still waiting for responses to many of those questions. Once we receive those responses, we will be incorporating those into our various materials before we make that prep packet available for purchase. We want to make sure that a lot of these issues are resolved or that we have answers to before sending out that prep packet. If you are interested in purchasing the prep packet when it's ready, please contact Michelle Knighton. Her contact info is available on the last slide of this presentation. So we are estimating sometime here in mid-March to have that information available to you. Please bear in mind that we are somewhat beholden to ONC's availability to answer a lot of our questions. The program launch we're anticipating to be no later than 3/31, March 31st. And next slide, please. So we do have a couple more upcoming webinars. Next week, the certification body will be discussing the certification disclosure and transparency requirements. Several of you may have been notified about this already if you already have certified products. They've actually extended the deadline for that, and we'll have more information about that next week. And in the following week, we'll be wrapping up the webinar series with the testing requirements for G3 through 5, as well as G7 through 9. And as mentioned before, you can register for these webinars at the link on that page there. Okay, next slide, please. Here are some resources we've made available to you. A link to the 2015 edition final rule, the ONC-approved test procedures, as well as the certification companion guides. There's a link to the Common Clinical Data Set Guide, which is a very useful document, as well as links to many of the 2015 edition test tools. Next slide, please. All right, so if anybody has any questions at this time that they have not submitted yet, please send them via chat to Michelle Knighton. And as the questions come in, we'll try to answer them to the best of our ability. Michelle, do you have any questions already?
Great, thanks so much, Kevin. We do have a number of questions. So the first couple of questions are about the criterion S5, the electronic case reporting criterion. And so essentially the two questions are related to the trigger table and how it's defined. And the other one is, what's the content of the triggers that are referenced. And so unfortunately, I don't have a lot of information that I can share with you at that time. When the draft test procedure for this criterion was submitted, there were a number of questions that were submitted to the ONC. I just checked the database as we were going through the webinar when I saw these questions come in, and they have not been addressed yet. So just know that we have, outstanding questions in the ONC, and hopefully those will be addressed when they have the criterion finalized, which hopefully will be this summer. And remember, the standard for this is still in HL7 balloting, and so I imagine that your questions will be answered once the implementation guide has been and the standard has been finalized. So the next question is, I'm happy, so Kevin, this is for you regarding automated measures. It says, I'm happy to see the reconciliation of measure names in G1 and G2, as well as the reduced number of measures. Will individual stage 2 measures be eligible for GAP certification treatment?
No. Unfortunately, GAP is not piecemeal, so the way ONC is defined GAP, it needs to be an entire criterion or not. So unfortunately, no.
Okay, great, thank you. And then the next question is also related to the G1 and G2 criteria, and the question is, are stage 1 reports required for those criteria?
No, they are not. The stage 1 reports have gone away. Moving forward, it'll be just the stage 2 and stage 3 reports as currently defined in the stage 3 final rule.
Great, thank you. And then the next question is, can you talk a little bit about what it means about using the direct backbone and what that means in reference to those EDGE protocols?
Okay, I can do that. So in 2014, the original draft of 2014 prior to R2, direct was basically the SMTP sending of mail messages between a HISP and a HISP. Now, it wasn't specifically called out like that in the criteria or test procedures, but that's effectively what it was testing, was more that HISP-to-HISP communication. So it was SMTP, which is a mail protocol, combined with SMIME, which was encrypting the attachments along with DNS and LDAP. What it didn't address was the communication between an EHR or a patient portal to the HISP. So for the vendors who partnered with the HISP, however they were submitting the CCDA documents from their technology up to the HISP technology, that wasn't tested. It was only testing the HISP-to-HISP communication. Now, some EHR products were operating as their own HISP, so there was no EDGE protocol involved. But especially towards the, as the program wore on, more and more vendors seemed to partner with other health information service providers. So for 2014 R2, they added in some additional optional criteria to do what they called EDGE testing. And now the EDGE testing is actually testing that communication from the EHR or patient portal to the HISP. If I had a whiteboard on the screen, I could probably draw it real quick. But if you think about the connection from endpoint to endpoint, from let's say EHR to EHR, you're going to use either XDR to communicate from the EHR to the HISP, or a combination of SMTP or SMTP with IMAP or SMTP with POP3 to communicate to the HISP. The HISP will use the traditional direct messaging that was a part of 2014, and then the receiving HISP will then again communicate with the receiving EHR via one of the EDGE protocols. So there's essentially 3 different connections that go on: EHR to HISP, HISP to HISP, and then HISP to EHR. So the EDGE is testing that EHR to HISP communication. So B1 requires EDGE testing only, because B1 would be, in this case, the EHR doing the testing. H1 or H2 is essentially for the HISP in this scenario that I'm discussing. And so they need to be able to do the EDGE to talk to the EHR, and they need to be able to do the direct backbone to talk to the other HISP. hopefully that provides some clarification. That may sound a little redundant. I apologize for that, but like I said, it's a little bit easier with a whiteboard. You can kind of draw it out. And if anybody has any further questions that they want to send me, I can probably put something together and send that out. It's like a screen capture or something after today's call.
Great. Thank you so much, Kevin. Then there are a couple of questions about the comment you made about the transparency attestation. So people just want you to confirm for them that that deadline was extended, and if you have the extension date, they would like to have that.
I was afraid of that. I believe it was extended until the end of this month, but I don't know that for certain off the top of my head. But yes, it was extended. We still need to get as much information as we can as soon as possible. But if you have questions about that, I recommend contacting Amit Trivedi or Diana Caniglio. I believe Diana's been contacting each of our customers to collect that information. So if you have any questions about that, you can respond to her previous emails, and we'll definitely have more information about that next week during the presentation.
Great, thanks, Kevin. And just to follow up on that, everyone should have received, if you're current customers of ours, you should have received an email from Diana earlier this week. And so if you just reply to that email, she'll be able to help you out with any additional questions you have. If you don't have that email, just send Kevin a message and he can get you in contact with her. So the next question is regarding the immunization criterion F1, and the question is, for NVC reporting to the immunization registry, does MU3 indicate workflow of how it must be captured by EHRs, or does it only indicate that it must be sent to the registry for administered vaccines? And so like you'll see in most of the criteria, the ONC does not dictate workflow. Essentially, it's not how you do it, but that you can do it. So your system simply needs to be able to get that data to properly formatted to the immunization registry. So the next question is, do we need to remove the ability to report stage 1 automated measure metrics from our system?
No. The decision to remove something like that would be presumably at your discretion based on what you feel is best for your customers. The way the criteria is written, it's at a minimum you need to be able to demonstrate this. There's nothing that requires the stage 1 to be removed. Certainly, that's not something that we're going to be testing for one way or the other. So if a product wants to remove those, that's fine, and if they don't, that's fine as well.
Okay, perfect. Thank you. And then I want to go back up to a question earlier about criterion H1. So Kevin, this is for you. So do products acting just as an EHR rather than a HISP need to demonstrate H1? So that's the first question. And then the follow-up question is, EHRs just need to worry about sending a standard CCDA file, not XDM, to the HISP, and the HISP would need to wrap them for direct communication to other HISPs, correct?
Okay, so the first part of that is a product acting as an EHR does not need to demonstrate H1. Now, the answer is a little bit trickier than the way the question is asked, so I'm probably going to give more information on what the person asking is looking for, but just so that everyone's clear. So the decision to test any of the criteria, of course, is optional, but where I think this question gets tricky has to do with the difference between becoming certified and being qualified as certified EHR technology. So to be certified, you can test B1, or you can test H1, or you can test them both. But to qualify certified EHR technology, you would need to do B1 and then either H1 or H2. Now, we anticipate that most EHRs would do B1 and most HISPs would do H1 and or H2, and then the end users would use multiple products in order to meet that certified EHR technology definition. So no, you do not, if you're just acting as an EHR, you will not need to demonstrate H1 for certification. Whether or not you need to demonstrate it to and certify to it to demonstrate the base EHR definition and qualify as certified EHR technology really depends on if your end users are going to be partnering with a HISP or if they're expecting your product to sort of incorporate that functionality for them. So it's a little bit of a tricky question to answer because it kind of depends on how that product intends to be used in the real world, so to speak. Now, as far as sending a standard CCDA file to the HISP, the answer is essentially correct. You just need to send the CCDA to the HISP via either XDR or SMTP, and then it is up to the HISP then to wrap the message and send it to another HISP in that wrapped format. So the answer to that question is correct. The EHR would not have to wrap it. Now, again, to similar type of thing though, as far as it kind of depends on your real-world implementation here. If the EHR is also acting as a HISP, then it would be expected to wrap it. But if that's not how your product is deployed in the real world, then if you're working with a separate HISP, then you don't need to wrap it before sending it to the HISP.
Great. Thanks, Kevin. So the next question is, I'll go ahead and take this one. It's, while G1 and G2 are individual criteria, we were and continue to be tested and certified on each sort of measure report. So the example given is, if I'm testing criterion, A1 for CPOE, then I'm probably also going to be testing the G1 or G2 measure related to CPOE. So essentially this person has said that the ONC's gap certification at the criterion level restriction doesn't actually match the test granularity of each measure, and that retesting existing reports is not efficient. So if you tested the 2014 edition CPOE criterion with a stage 2 report, you should be able to be exempted from that. And I love the question. However, this is a policy decision at the federal level. It's not something that we at ICSA Labs can modify or change for you. I would certainly highly encourage you to submit that commentary to the ONC. They may or may not change their minds on that. They may not, because the final rule is final at this point. But it's certainly worth asking and sort of asking them to noodle on that. So the next question would be for you, Kevin. For certification of direct, the requirement is for the vendor to obtain 3 unrelated partners. Can you provide more clarification on unrelated?
My interpretation of that is that it might be a situation where one vendor had multiple products, and you couldn't just test with the multiple products from a single vendor, but they must be autonomous vendors of that technology. So that's my understanding of the requirement, but we could follow up with ONC and get clarification on that, and I'll make a note to do that here. Okay. So yeah, but again, my understanding is that the products themselves have to be from different providers.
Great. Thank you. And it looks like there are a couple of other questions, but it looks like, and I can go ahead and read them, but we'll need to follow up with you after the call because I don't think decisions have been made on some of the biggest things. So one of the questions is, if we test a clinical criterion and its associated required security criteria, so let's say it's like a phase 1, and we test A1 and all of the associated security criteria. And then we come back and we want to test and certify on another clinical criterion that requires the exact same security criteria. Can we simply inherit the security test results from phase 1 to phase 2, so long as those functionalities are the same for the new criteria? I want to say yes. However, that is sort of a programmatic decision that would need to be made. And so what I'll do is I will keep your name so that I know who asked the question, and I can certainly follow up with you once I have an answer. The next question is the immunization criterion still not required for EHRs whose providers are not licensed for immunization. And so what I would say is we can certainly follow up with you afterwards, but our focus right now for this webinar is certification requirements versus meaningful use requirements for the providers. So we would need to dig into the requirements for the CMS program. And so if you want to follow up with me afterwards, we can certainly look into that together. But right now we're only prepared to discuss what the ONC certification requirements are. And it looks like that is the end of our question. We can hang out for just a minute or so. If you have anything else that you're burning and have a deep desire to ask, please go ahead and submit it via the chat. Otherwise, we'll go ahead and close the call. So we'll give you just another minute to do that.
And while we wait, I just want to add one more clarification to the question about the unrelated partners. I think this kind of goes without saying, but it's probably worth stating it anyway. Obviously, you know, when we talk about unrelated, at a minimum, it would be unrelated to the certifying vendor themselves. So if a developer has, you know, let's say they're creating 3 of their own EHRs, it would not be sufficient for them to demonstrate interoperability between their own products. They definitely have to demonstrate interoperability with a completely different organization. And then I also believe that that applies to different products from different organizations. So I just want to add that clarification. It wouldn't be enough to test internally. It needs to be external organizations that have technology.
Great. Thanks, Kevin. And so another question did come in asking what is the final date that certification must be achieved by? And so what I can share with you is based on what we currently have in the final rules for stage 3, meaningful use, so from CMS, as well as the ONC's final rule for the 2015 edition program. So the current CMS final rule for stage 3 talks about systems needing to use 2015 edition certified software as soon as they're ready for stage 3. So some, and no later by 2018, so January 1st, 2018. So you definitely want to be certified by then. However, I would recommend that you survey your clients because some of them may reach stage 3 in the year 2017, in which case you would want to receive certification by the end of this year. But that is going to vary widely for all of the different developers that are on the call. So we just recommend that you kind of survey your client base and see what they're looking for that. Kevin, you may not be able to answer this, but I'm going to run it by you anyway since it's a certification question. So is there a template for the quarterly adaptations and updates report?
Yeah, I'm not able to answer that at this time. I would have to speak with our team internally on that one.
Okay, so what we will do, Phil, is we will take your name and I'll give Kevin your information, and Kevin will follow up with you once he's had a chance to discuss internally. Okay, great. Okay, so the next question is from Laura. And so, Kevin, this is on criterion G6, so CCDA creation performance. And so the question is, the slide for that said we need to use HL7 version 2.1. However, when reading the information on the ONC website, I'm seeing HL7 version 3. Can you help explain the discrepancy? And I'm looking at the companion guide that lists all of the standards, and I'm seeing that it's all CCDA templates for clinical notes, release 2.1, HL7 implementation guide for CDA release 2, for clinical template for clinical notes, draft standard, trial use, release 2.1. I'm not seeing HL7 version 3. So Laura, if you want to just follow up with me and send me the link to what you're looking at, we can try to reconcile that for you. Next question for Kevin. In the old G1, 2014 G1 criterion, using the common IMMU data set, we had to use immunization data for the test. but we didn't actually have to test on any immunization criteria. Is that still true?
It's actually a very good question. Let me check the CCDS reference real quick, and I should be able to give that answer. Yes, so immunizations is part of the common clinical data set, and if I can infer correctly here, I think the issue is for some vendors who don't support immunization testing, they didn't have a feel for immunization data, so creating a CCDA with the immunization data proved to be a bit of a challenge. But it does appear that the immunizations are still required for 2015 in the Common Clinical Data Set.
Okay, great. Okay, I'll give it just a few more seconds to see if any other questions come in. We have about 4 minutes left, so we can entertain more if you have them. If you don't, though, that's perfectly fine, but we'll give you just a few more seconds to submit any follow-up questions that you might have. Okay, I don't see any, so we'll go ahead and wrap up today's call. Thank you so much, everyone, for joining us. We hope you'll be able to meet with us next Thursday as well when we talk about the certification disclosure requirements. And then again on the 24th, both meetings will be at 2 in the afternoon Eastern Time. And on the 24th, we're going to be talking about the remaining design and performance criteria. So thank you so much, and we will follow up with everyone once this recording and slide deck have been posted to our website. Thank you.